morning, everybody. Welcome. Well, morning Pacific time. Hey, everybody. Welcome to today's OpenNotes GrandRounds webinar with Dr. Christian Sinclair. My name is Liz Salmi, and I'm the Senior Strategist of Research Dissemination for OpenNotes. And I'll be introducing you to the cast of characters along the way. Before we keep going, I want to quickly review some housekeeping for today's webinar. All of you who are signing in right now, 200 of you at this point, or up to 500 today. So all of you who are signing in are muted throughout today's presentation. Please put your questions throughout the webinar in the question section of this platform, and we will address all questions, hopefully, at the end of today's presentation, and we're saving your questions as well. This webinar is recorded and will be available for later viewing on our website at opennotes.org and also our YouTube channel at youtube.com/myOpenNotes. You will also receive an email in a few days with links to those recordings. So the number one question is, will we get links to the recording? And the answer is yes, and we'll repeat that throughout the day. I recognize today we have a brand new audience joining OpenNotes for the first time. And if this is your first time hearing about a group called OpenNotes, I want to let you know that OpenNotes is based at Beth Israel Deaconess Medical Center in Boston, Massachusetts. As researchers, we've been studying the effects of shared clinical notes on patients, their care partners, caregivers, and the effects on clinicians for over 10 years. OpenNotes, we work with collaborators around the country and overseas to foster and evaluate the spread and effectiveness of shared clinical notes. And when clinician notes are shared with patients, we call them open notes. We are funded entirely by federal and philanthropic grants and gifts, and we do not create any software or technology. OpenNotes is a philosophy, a movement. So we are really excited for today's presentation on sharing palliative care notes with Dr. Christian Sinclair. But first, I'm going to hand things over to Dr. Kate DeRoche, who's going to talk for a few minutes to set the stage for Dr. Sinclair by sharing a bit about a new federal rule kicking in just a few days that will mandate the sharing of clinical notes with patients. And Kate is also going to attempt to cover about a decade's worth of research around OpenNotes in about 5 slides. So good luck to her. Dr. Kate DeRoche is the director of OpenNotes at Beth Israel Deaconess Medical Center and an associate professor of medicine at Harvard Medical School. Kate, take it away.
Thank you. And thanks to everyone who signed on to join us today. We are very excited about this webinar around palliative care notes. So I'm going to just very quickly go through my portion just to give everyone a little bit more background information. Patients have had the right to see their notes since 1996 when HIPAA was passed. You know, it's a really complicated piece of legislation, but the easiest piece of it to understand is that it gave patients the right to request and access their medical records. But it's not easy for patients to get their records that way. I mean, you have to pay for them, you have to sign a lot of forms, you have to trundle down to the sub-basement of your local hospital to try to get your records. So it's not easy. The second piece of legislation that gets us to where we are now is the HITECH Act. So that act incentivized hospitals and clinicians to adopt electronic health records. And one of the things that they had to do in order to get these incentives was have a patient portal where patients could log in and do some very basic things. So that set that set us up with the technology. And then the third piece of legislation was the 21st Century Cures Act that was passed under the Obama administration. It was the last major piece of legislation passed under the Obama administration. And that was primarily about biomedical research and innovation, but there was a piece of it that essentially directed the Department of Health and Human Services to improve data interoperability. So how data flows between providers, between organizations. And then there was one line in it that I'm going to paraphrase that says that patients should have electronic access to all of the information in their electronic medical records. So fast forward 4 years later, many discussions about what all means, and we have the interoperability and information blocking rule. This rule takes effect next week, November 2nd, and it requires a greatly expanded set of information to be electronically shared with patients without charge, and it includes progress notes. This is sort of a graphic of everything that has to be exchanged between providers and made available to patients, and I'll just draw your attention to the clinical notes piece. There are 8 kinds of notes that need to be shared, and they include progress notes, consultation notes, discharge summaries, history and physical, and reports, so labs, imaging reports, pathology reports. So just to take a step back for a minute, why is this important for patients? So what I'm showing you here is what a patient typically sees in a portal, and we've found over the years that many providers don't actually know what the patient portal interface looks like. And so you can see on the left side of the screen, this is a typical after visit summary for Liz, who has agreed to share this with us. And it includes very basic information about her, vitals, what she was there for. Yep, she's still, still the same height. And in the middle is what she can see typically on her phone. On the right is the note from the same visit. So you can see that the note is a much sort of richer source of information. So that's why, that's the policy. That's why it's important for patients. And a brief bit of history for people who didn't hear Liz say this early on. OpenNotes is not a software. We're not a vendor. We're not creating an app. We don't have a server full of notes. We are a philanthropically funded research initiative that focuses on what happens when patients are given access to their notes. So it started as a pilot in 2010 at 3 organizations in Boston, Seattle, and rural Pennsylvania. There were 105 primary care clinicians, and there were about 20,000 patients. And as part of the evaluation, patients and clinicians were surveyed before and after the pilot. Patients reported substantial benefits around feeling in better control, understanding their medications, and clinicians, while very worried before the intervention started, kind of said, this was okay. This, in fact, we had one report of a clinician saying, are you sure that this is turned on? Because I'm not really hearing anything from my patients. So we recently went back and resurveyed at those 3 sites. In the intervening period between the pilot and now, all 3 of those sites opened all of their ambulatory care notes. So across every ambulatory care setting, patients were able to read their notes. We went back and surveyed them 7 years later and found patients were still saying, these notes are really important for taking care of my health, remembering my care plan. Patients were saying they understood all or nearly all of what's in their notes, that reading their notes helps them understand their medications. About 1 in 5 found an error in their notes that they thought was important. And significantly, we found that patients who have lower levels of formal education and limited English proficiency or limited English proficiency were more likely than other patients to report these benefits. And for clinicians, we were worried because we weren't sure that the clinician findings would hold when we moved out of just primary care, but we found that the majority of clinicians, after sharing notes, said that it's a good idea for patients, it's helpful for engaging them. Most would recommend the practice to colleagues. Very few report questions or concerns. About a third say they're spending at least somewhat more time in documentation. We don't really know what that means, although we have seen some other smaller studies that show that the actual amount of time is minimal, like a few seconds, but it could feel like it takes more time, particularly as clinicians are getting used to the practice and they're thinking, well, maybe I need to change a little bit about what I'm doing in order to, because now I know patients are reading. So over the period from 2010 when the pilot started to just right now, before the rule goes into effect, we know of over 250 healthcare organizations that are sharing notes with about 53 million people in North America. So these are, just to be clear, this is 53 million people who are signed up on a portal at an organization that shares notes through that portal. So tremendous amount of spread over the last 10 years, and we expect, you know, of course, now everyone's going to have to do it. So we're very excited about that. So that's it for me. I want to get to the main event. If you have questions for me, there's my contact information. Feel free to shoot them my way. And I'm going to turn it back over to Liz now.
Thank you so much, Kate. So I'm drum rolling. All right, we're on our way to the main event today. We are so excited. Everyone who works on OpenNotes, we all happen to love palliative care, and we've been so excited, like, what's going to happen when OpenNotes rolls up in palliative care? Who's going to be looking at this first? We haven't done specific research on OpenNotes in palliative care, so those who are doing this as early adopters are really fascinating to us, and this brings us to our presenter today. Dr. Christian Sinclair is an associate professor of palliative medicine at the University of Kansas Health System. His contributions to the field of hospice and palliative care have focused on using social media as a public health tool through his work as editor-in-chief of the website PalliMed, which I've been following for a long time, and as associate social media editor for the Journal of Pain and Symptom Management. In 2016, Dr. Sinclair served as president of the American Academy of Hospice and Palliative Medicine. Like I said, here at OpenNotes, we've been following the work of Dr. Sinclair, as he is one of the first early adopters of OpenNotes in palliative care, and we are super excited to hear from him today. So take it away, Dr. Sinclair.
All right. Well, thank you very much, Liz. That was a great introduction. And Dr. DeRoche for your wonderful overview of OpenNotes and where we've come in such a short time, but we have come quite far. I'm really excited to see a great turnout from palliative care clinicians and people who are interested in OpenNotes, because I really think there is a lot of synergy between palliative care and the whole idea behind OpenNotes. So this is coming at people pretty fast, though. Some of you may have heard about it a long time. Some have just heard about it just in the past week. But I want to give you tips and tricks to help you feel confident in how you approach your notes, especially in the next several weeks as this rolls out at institutions. Some institutions have already been doing this, but everyone's going to be seeing this November 2nd. So let's get to the tips. We have a lot to cover in a short amount of time, because we do want to leave lots of time for questions and answers and discussion. And for those of you who may have come on late, this is going to be recorded, and this will be available on the OpenNotes website, so you can go back and look at slides in more detail if I'm a little bit quick on the trigger and you didn't happen to get a screen cap or anything. So my agenda, my overview today is to talk about shared notes in general, and I use the term shared notes because it's OpenNotes, but OpenNotes, I want to make sure everyone here knows OpenNotes is the organization. And your own healthcare organization may call it OpenNotes internally, or they may say shared notes or use a different term. So, so we're going to talk about how to do shared notes in general, how to do it well, the benefits, what patients think, some concerns, some tips and tricks, and then we're going to talk about some specific palliative care areas. And I've been sharing notes for over a year now, and I've learned a lot. I've both through great successes and just a couple of missteps, and I want to share what I've learned from that and what I've learned from reading the research, what I've learned from doing lots of sessions, Q&A sessions with people at the University of Kansas, people online. So I'm going to share some tips that are more related to palliative care topics that this audience would care about. So some background in palliative care. I think a lot of people on here are palliative care clinicians or palliative care and hospice advocates, but I want to just highlight something from the National Consensus Project on the Clinical Practice Guidelines for Quality Palliative Care. In the 4th edition that was just recently released, it highlights communication as a theme that goes across all of the ways that we provide quality care. And this statement, I just want to highlight that communication is a prerequisite for delivery of quality care for the seriously ill, and is emphasized throughout the National Consensus Project. And it does say communication with patients and families. Palliative care and hospice people know from our training, from our work experience, that how we communicate with families is something we talk about a lot. We learn about, we go to conferences for it, we read articles about it, we research it, but a lot of it is focused on how do we verbally communicate and non-verbally in the room and a family meeting. But we have to realize that our written word is another communication tool, and we have to figure out how do we use this tool for the best benefit for our patients and families while still preserving our sanity and our professional workload. So Dr. DeRoche did a very fantastic job talking about some of the research, but I want to come back to it again because I just want to reinforce this. There are lots of benefits for OpenNotes, and as we think about this, think about how, I could say at the top, benefits of palliative care: improved communication, patient engagement, improved outcomes, improved safety, optimized care, fulfilled patients. Like, the title could probably be switched between benefits of OpenNotes and benefits of palliative care. So OpenNotes and palliative care, very aligned. From other research, the majority of patients report that they want continued access, that when they use it, it helps with adherence, they feel more in control, better prepared, they have a better understanding of their own healthcare, and they take better care of themselves. So these are just a couple of quotes from this great study. I love qualitative research for the quotes it gives because I think it tells us the story better sometimes than the charts. But look at this: trust, confidence, collaboration, understanding, engagement. Again, this is all from OpenNotes, but these themes are things we love to see in palliative care. So some of the quotes here: reading the notes made it easier for me to understand what the doctor has said and what I need to do. It gave me insight into the evaluation process my doctor used and gave me confidence in his abilities. I'm more relaxed during the appointment in that I don't have to remember every detail. So lots of great things from sharing our notes with our patients that can happen. So I know I've said all these benefits and you're like, shut up and take my money. Like, I want to have this right now. Why haven't we been doing this before? But I also know there's some of you who are a little bit more skeptical and maybe not the early adopter that I am. And you may be thinking, well, that all sounds great, but there's got to be some trade-offs. There's some things that I'm really worried about. Well, let's take a look at those. What are the concerns that people have? Well, patient factors. We're going to spend time spent responding to these patients. They're going to say, oh, you got to correct this, you got to correct that, or that's not what I said, or you didn't tell me about that. And so we're just going to have tons of new email or EHR mail that is going to slow down our workflow and decrease our potential satisfaction. That's a potential concern. Maybe patients will get upset, anxious, sad, or angry, and that will be hard for us to deal with as clinicians. Maybe we're going to confuse patients and potentially cause harm, or maybe there's increased malpractice liability that they're going to see something in the chart that makes them think, now I need to consider a lawsuit. Well, the experience and the research shows that these issues, while there are concerns, on the whole, they are not a widespread issue that comes with OpenNotes. Now, I'm not going to say that no one will ever ask you to correct, that no one will ever get upset or anxious. I've had people from my OpenNotes that have gotten upset with me and what I wrote in there, but I changed my practice. I talked to them, I learned from them. I am a better documenting clinician now because of that, and I want to share some of that with you. So by the ones on the cases, yes, sometimes these things will happen, but on the whole, these things are not the large concerns that we're seeing. And I know from hearing from Dr. DeRoche before that some healthcare institutions malpractice, their insurers basically say, we want you to do this because we think the communication will decrease malpractice liability. So those are the patient factors and concerns. What about the documentation factors? Well, you're asking me to do something different with the notes, which already are not something I love at the end of the day during pajama time. More time documenting, less accurate notes. Is this going to change my billing because I'm going to write stuff and then the billers and coders are going to say, well, you didn't say severe malnutrition. You said, well, I said the patient is not eating well because I tried to make it more friendly. All of these things and the sensitive topics, they aren't non-issues, but I think with more information and a little bit of curiosity and some small changes in practice, we can tackle these. These are not insurmountable issues that should paralyze us from going forward with OpenNotes with open arms. So let's talk about some general shared notes tips. And going to highlight some different areas. There's pre-visit, during visit, documenting, and follow through. if you don't take anything away from this except for one thing, all I want you to do, like if you have to go, I mean, you got call after this, please go read the OpenNotes website. Dr. DeRoche, Liz Salmi, and the team there have done a great job at putting a lot of resources there for you to look up. So you'll see a lot that I'll say, look at the tip sheet on OpenNotes, look at the tip sheet on OpenNotes. So if you take anything away or you need to share something quick with your colleagues who couldn't make it today, tell them to go read the OpenNotes website. It's fantastic. So entry level. I'm going to talk about entry level and pro level tips. And entry level is like, we've got to be able to do this pretty much from next week. But I think it's very easy to accomplish for most palliative care people. First thing is, expect that patients are going to read them, download them, share them. You're going to encounter situations like that. And honestly, we probably should have been writing our notes prior to OpenNotes. We should have been writing our notes like that anyway. A very basic thing that we need to start doing is working on our in-visit communication. Explain to patients what they can expect to see. Just even introduce the topic. Many of our healthcare organizations have been slow to talk to clinicians about OpenNotes, but guess what? They've probably really, if they've talked to clinicians, they may not have even talked to patients and families. So they may be just getting alerts in their phone like, oh, I can see a doctor's note. I've never seen that before. So you in your visits, you may want to say, after I write my note, you're going to be able to see it. That would be a great thing to inform them. And they're going to think, wow, you're a wonderful physician or nurse practitioner or social worker who just helped me understand that I have more access to information. So kudos to you. When you write your notes, be clear and succinct. Again, should be a good, strong general principle for any documentation. But particularly for patients, we want to watch out for too much jargon. And if there's acronyms, we want to think about spelling those out. And you think, oh, great, BID is so easy to write all the time. You can set up smart phrases and other shortcuts in many health record systems that will allow you to type some of those things out easily. But I think it's important for us to also look at acronyms that might be confusing or misunderstood, like shortness of breath. May mean something very different to the general public than it does to a clinician. And other acronyms that may have different meanings as they go to see different specialists. So thinking about if there are times when you're going to use an acronym, maybe spell it out once, like you might do in a research paper at the top and say what the acronym is, and then just leave it there. Then you can maybe use the acronym more through the note. Your note should be direct and respectful. So avoid speculation about intent or motives. Really kind of stick to the facts and be direct. And your language should be more neutral and factual, and make sure that it's more person-first language. So it's very common to see in notes morbid obesity, but you can talk about class 3 obesity, as that's actually more technical and factual and a little less pejorative. Or you can talk about direct facts like body mass index of 42. Instead of diabetic, a person with diabetes. And again, most of us probably think and talk and document like that in palliative care, but maybe not. And if that's new to you, or maybe you've been doing it before, but you didn't know it had a name, it's called person-first language. And so describing the person as they have a condition, as opposed to that is who the person is. It says patient denies, say Tanya did not report, instead of saying poor historian, Sam could not recall. I'm a big fan of actually writing the person's name multiple times in the chart instead of using the generic term patient, because then I actually get to personalize and feel like I'm more connected to the information I'm sharing, and it's connected in my mind to that patient. More entry-level ideas, use supportive language. This is a great opportunity. Your notes are now communication tools. They're therapeutic interventions potentially. Your notes can help people see their strengths. So when people are sharing how they're coping with something and you feel that's a very constructive way, make sure you highlight that in your notes and reinforce that. So maybe when they're reading it later, they realize, oh, my doctor sees my strengths and he doesn't just see me as a collection of illnesses. With OpenNotes and really trying to be more accurate, we want to think about how we use quotes, and I think quotes are very helpful. But I think it's important to use quotes maybe more for short, memorable phrases that really pivot the conversation or give character to the conversation. I've seen oftentimes in palliative care notes and other notes where there's these very long quotes. And very long quotes are hard to remember unless you're actually recording and transcribing it. So when you write a long quote, there's probably more room for error. So instead, use the sort of short, memorable phrases that really emphasize, and use your own language to paraphrase the other ideas. I think that would probably be a safer way to use quotes. Realize that ICD-10 codes may be in part of your billing, your after visit summary, your actual note, and they may have things like morbid obesity in the ICD-10, but doesn't match your language, but just recognize that your patients may be seeing that. And lastly, don't oversimplify your notes. Don't just go to one other extreme and change your practice completely and make things so basic and lay focused that you're avoiding good clinical communication. And don't avoid sensitive issues. We need to figure out a way to communicate these with respect in ways that help advance the patient's care and still reflect the situation. So let's get to the pro level. Those are the things you should hopefully be able to do as a team pretty quickly, because you probably already do most of them, so probably not too much change. These are the pro level. These are the things that I think you can really start to get better at it and become more of an expert, maybe help your teammates, help other specialties and other disciplines that you work with that are outside of palliative care get better, and you can feel more confident in your knowledge. So definitely go read OpenNotes. Have a meeting with your group. I know there's not much time, but guess what? Even after this starts, you can have a meeting in a couple weeks with your group to say, let's sit down and talk about this. Take a look at the note templates that you have in your EHR. Are they already patient-centered, or are there things you can do that make them more patient-centered? Our group at the University of Kansas looked at the way we make our stub about prognosis, and how we think about how we document prognosis, and we readjusted that. What common phrases might need to be altered that your team uses a lot, and kind of brainstorm and come together and say, instead of this, we should say this. If you are a specialty and palliative care doesn't have a lot of acronyms, but maybe for your other colleagues in different specialties, if we have a lot of acronyms, make an easy acronym list and hand those out to your patients at clinic visits or in the hospital to say, hey, these are acronyms you might see in my note, and I just want you to know what they are and have an easy reference guide. At the pro level, you got to know what your organization is doing. Yes, in the United States, this is a national mandate, but your organization may be doing things very differently. Lastly, you can volunteer on your OpenNotes team, and you might need to know how many patients are actually using your EHR portal, and potentially can look at your notes. During the visit, talk about shared notes. I talked about that as entry level, but really open up that conversation. I found that's been a great way to connect with patients and for them to be more likely to go look at the notes, but also give me feedback because I've asked for it. Some people actually document and dictate with the patient in the room. That's not really my style, but some people can do that really easily. And then also just another pro level, there's Our Notes initiative, which talks about patient-generated notes to add into the electronic health record. So that's more. So I'm going to speed through these a little bit faster because I do want to get to the palliative care stuff. So there may be stuff on here that I don't verbally hit on, but you can read and go back to later. There are citations at the bottom for some things that are cited, but a lot of this is through general experience and hearing from different people. It's not published yet. Again, you've gone through the visit, you're documenting now, use your EHR smart phrases to easily spell out acronyms or correct non-patient-centered phrases. So you can do something like in Epic that if anytime you type diabetic, just because you're just typing really fast and you type diabetic, it actually changes to person with diabetes, which can help you or may be confusing if you said diabetic medication. So think about those smart phrases, make the computer work for you. If you talk about future plans, it's really important in your plan to say you may consider this in the future, because if your language says, consider starting methadone, need to check EKG, and that's something you haven't necessarily discussed, but you're talking to your future self, how you phrase that may really be understood in different ways by patients. So if you use notes as a way to talk to your future self, to give you ideas of things you need to check on or follow up on, make sure it's clear what is really more something you consider or an instruction you're giving the patient. I I like to include a shared note statement, which is after my signature. It comes in automatically. I don't type this out, and it just highlights this is a shared note. I support patients' rights to see their health information, and we're partners. And if they have concerns, this is the funnel that I'd like them to address those concerns with us, because I don't want them reading something on a Saturday morning, getting extremely anxious and feeling like they don't have a way to address this until Monday. So you've already documented. What do you do after this at the pro level? Well, once this starts happening, talk with your patients. Did you read the note? Did you read other people's notes? Did what you read from the cardiologist or the transplant physician, did that make you concerned? Do you want to talk about those things? Again, that's a way that palliative care can help share information about the patient's health across different specialties. You can really go the extra mile and start tracking patient successes and failures with shared notes. That if you do that well, that may even be publishable. Tracking who is actually accessing it, and then sharing best practices within your institution and outside your institution. And again, I'm going to put out the call out there. There are no palliative care directly focused articles about OpenNotes. There are close ones and things that address what we do, but there's not really a body of work and research or even quality improvement around this topic. So go at it. We have lots to learn. Some things when you're thinking about how much you're using the chart, I just want to highlight this if you don't know about this. Systems like Epic and Cerner have ways that you can actually look at how often how much time your clinicians are spending on this. Not going to go into details, but you can ask that from your EHR support team. So let's get to the unique areas in palliative care. Prognostication. It's important. We need to think about it. We should probably document it, but it's really changes how many of us may have used prognostication documentation before. We may have used it more to talk to our future selves or to talk to other clinicians to kind of put our flag out to say, I am concerned this patient has weeks to months to live, and how will that impact their care? Well, now that we're in an area where OpenNotes are there, and if you document that, but you haven't shared that, or you share that in a euphemistic, indirect way, that's going to be quite a potential jarring shock to patients. And it's not something that we would probably want to do verbally and communicate it that clunky in a clunky way. So we need to think, if we haven't said it to the patient, then we need to really think about, should we document it? And conversely, if we're planning on documenting, we really think it's important enough to document, then shouldn't we really put that into the conversation in obviously a permission-based way if the patient is open to talking about it? And again, we can use this as a way to advance care. So maybe the patient doesn't want to talk about prognosis. You try to open it in the conversation, try to address it in a couple different ways, but the patient said, I don't want to hear about this. Well, think about having a smart phrase and that says, the patient prefers to avoid prognosis discussion. That's factual. But you can also add, I'm hopeful we can discuss in the future to better plan together. That's a really positive, synergistic way to say, this is something we can do together, and I'm open to talking about it, and that may open doors further down the road. Just a quick highlight here. I use the word smart phrase. That's very common in Epic platforms, but basically I use that to say a way that the computer can easily type out a longer sentence using a shortcut way. So different EHRs have different terminology for that. Advanced care planning. So first of all, you need to know different orgs are interpreting what they need to share slightly differently. Yes, it's a federal rule, but how your healthcare organization decides to what exactly to share may be different. So you may have advanced care planning notes, they may or may not share them. So figure that out first. When you're documenting an advanced care planning note, it is important to consider reviewing that note at the end of the visit or maybe in the future. So let's say you have a good advanced care planning discussion. Say, hey, this was a great discussion. I'm going to write this in the chart. I really want you to take a look at it after I close it. If you have any changes or adjustments to make, let me know, because this is really going to direct their care potentially in a time where the patient doesn't have a voice. And so if you're able to get their feedback and input, that's going to give you a lot more confidence as a clinician that what you documented really reflects how they feel. I think a great example of this is we hear patients say all the time, like, they may say, I don't want to go to the ICU. Well, a lot of people don't want to go to the ICU, but people who say that may say, but I will go to the ICU. And people can interpret a statement, if you put it in their quote, say, I don't want to go to the ICU, as a limitation on what level of care they want. But they may just say they have no, that means they have no desire to, but they're perfectly willing to do that if that's what it needs to happen. So I think that's where it's important to get some feedback on how we document advanced care planning notes. If you avoid parts of the discussion based on how you're reading the situation or the patient's not wanting to go into that, definitely document the attempt, because I think that could help, again, advance that care further down the road. And if you want to do QI or research, that may be a great opportunity for us. A different area that we care about and EHRs are still figuring out is how caregivers and proxies access the information for the patient. It's important to recognize that caregiver roles vary across an illness. They may just be technical support, or they may be representing that patient. And still, we're in a digital technology era where our habits may be sharing passwords on pieces of paper or taking advantage of a customized proxy account that the EHR can allow you to set up. And even those proxy accounts, they may be proxy accounts that have full access, limited access, or customized access. So it's important for you to understand what your health record looks like from the patient and the caregiver point of view. If you don't know that, spend some time with your EHR teams and explore that. If you're concerned about documenting sensitive information, ask the patient. And I have some quotes for in-visit language that you can use. But if it is sensitive info, it's important to say you want to document that information, and if they have concerns about it, I think it's important to listen to them. It doesn't mean you have to follow exactly what they say if your requirements for documentation and the patient's safety and professional obligations and ethics overrides that, but I think it's important to have that discussion and understand how the patient may or may not feel about your documentation. If there is a safety concern, many EHRs have a way to mark the note as sensitive. That may be a clinically excellent idea to the system, and how this may look to their reporting is that is likely to be considered information blocking, and generally a negative if it gets too much. So it is okay to mark a note as sensitive and maybe not share it with the patient, but you should hopefully be able to back up the reasons for that, so that if your organization comes back to you and says, Dr. Sinclair, you're marking 95% of your notes sensitive, that's way outside the range for the rest of the clinicians. Can we talk about why that is, and maybe we can address some different ways to do that and really get that sensitive notes down to maybe 5% or 10%? That may be more reasonable. So you may hear from your organization if you mark a lot of notes sensitive or not shared. Not going to go into issues here, but definitely incarcerated persons and who makes decision for them and their access to healthcare information definitely has its own particular issues. Children and adolescents, can't leave out our pediatric colleagues who do great work in pediatric palliative care. Again, start with what is your organization doing with these notes? They may be handling these very differently. And also, what are your current capabilities to customize access to this? We know from the research that sexual health in adolescents and other sensitive topics like substance abuse or genetic data is well documented from an ethics standpoint, but there's not a lot of information, although there is some, about how that operates in the shared environment of OpenNotes. And so we still need to really figure out what are our norms here, and we need to have discussions and figure out best practices pretty quickly. Because we're addressing that growing autonomy of adolescents, but also the parental supervision of them. It is very challenging. There is a pediatric toolkit at OpenNotes that will give you a great head start, but if you're encountering problems here, guess what? Someone else probably is too. Figure out what that problem is, share that information, spread that knowledge quickly so we can figure out best practices sooner. Our social workers, our psychologists, our psychiatrists also deal with very sensitive issues, and behavioral health and confidentiality has a long history, well documented. But again, in this new world of OpenNotes, we're still making sure we figure out what the norms are and what the ethical standards are. And so we need a lot of discussion around that. If you are talking about diagnosing somebody with a psychiatric disorder, then I think it's important that you talk about what those possible diagnoses are before you document it. It's one thing to have a conversation and then go into your document and say, I think that patient may possibly have schizophrenia or bipolar disorder, and you never said those words in clinic, much like the prognosis statement. That could be very jarring to see for the first time in documentation. So I think this OpenNotes era documentation may actually make us better in-visit communicators to talk about these very sensitive issues in a way that helps advance the patient's care. Also, this is the area where ICD-10 codes, it may not be in your narrative documentation, but it may impact what the patient sees and how they feel about their own mental health. I like to use, when I'm talking about potential depression, anxiety, I like to use probabilities and use words like probable, like it's possible that they have major depressive disorder. I'm not necessarily in that moment diagnosing them. Maybe it's my first visit, but I want to put that on a differential there. And so put out a wide range of things. And I may say in my visit, you know, all the things you shared with me today, it has me concerned that we may need to look at some diagnoses that may help us better understand why you're feeling that way. And talk about those a little bit more so that I feel a lot more comfortable documenting that. I like to, in my notes to also say, may need more formal assessment, and that cues future me to say, do we need a referral to psychiatry or to work with psychology or social work to help get a wider, deeper assessment. One of the benefits too, as I said before, this can be a place where we can show respect, destigmatize, and actually be a tool for change and help in the health and behavioral health issues. Substance and opioid use disorders. This is a very tricky area. These are also covered by confidentiality laws, but they have to do with, are you a federally assisted program or not? And this is really complex stuff. State laws too about how you document this is even more complex. Before even getting into this talk, how I document about this, I haven't really had a standard, and the more that I researched on this, the more that I think it's going to be important for us to have conversations about how do we do this well. But again, it goes back to, if you're thinking about putting this in the chart, that you discuss these possible diagnoses before you actually document them, so that you are really sharing your professional assessment. Again, this is another area where I like to use the weighted words for different probabilities. And lastly, in these issues, really avoid becoming a detective in your notes. I've seen this in different people's notes where there's speculation about what they're doing with their medicines when there's no evidence that they're stating that the patient is distributing them to somebody else. So really be careful with your notes about speculation of motives, intent, and things that you don't have knowledge about. Requests for hastened death. I think it's important to understand what your state laws are for medical aid in dying, but we know that regardless of state laws, that these requests can come to us. And so, it is important to document these requests respectfully, humanely, factually. And if you're figuring out why the patient is asking for this, make sure that this is a great place to use patient quotes of phrases for their values, their reasoning around this. And again, avoiding speculation. If a family member just said an offhand comment like that, you're trying to speculate why they said something about these medicines hastening someone's death. This is an area where our speculation could really not characterize the situation very well. Other things that I know we do in palliative care notes is we may try to evaluate relationships, that if there's tension between a patient and caregiver, they share very intimate details with us, and they share details that they may not share with each other, their frustrations and their worries about the other party. And we know that patient caregivers trust us with that information. And so thinking about how we document in the note, if a caregiver shares some private feelings about the patient, but you're writing in the patient's note and the patient's going to see that, that can be pretty much equivalent to you going into the patient and say, do you know what your caregiver just told me? So we really need to think wisely about how we document that. And sometimes this may be a place where we need to think that note might be sensitive for particular reasons. And then in the future, instead of making all your notes sensitive from that point forward, you can refer people back to that sensitive note if you're needing to talk with other clinicians. And again, this is an area we can use the note as a tool for benefit to highlight the strengths. We also may talk about how patients coping, if it's destructive or constructive coping. And so I think it's important, especially for negative coping mechanisms, that we find language that captures what's happening and work with your team to find what's the best wording and aim for being factual, neutral, and professional, and match the language that you use in your visit. And this is a really important point. The language we use in our visit and what we document may not be the same. They're the same in our head, but they may not be what we said to the patient. And I think OpenNotes is an era that we're going to have to start thinking, I have to document a lot closer to what I said, as opposed to the 3 conversations I was having in my head and thinking through it. Because once we start documenting, all those conversations kind of come together, and it feels like we might have said that to the patient, but we were only thinking about that, or maybe we thought about it and debrief and talked about it in debriefing with the team, but we never really said that to the patient or the caregiver. So try and use similar language in your documentation that matches what the patient and caregiver heard, as opposed to what you thought or what you and your team discussed. So we also use notes for teaching, to talking to our future self and making plans, handing off to colleagues, hopefully not fighting or arguing with other teams. But I think we might be asking a little bit too much of notes to do this, and we might need to really think, are there better ways to do that? So I think that's something that we can probably take off the burden of what we do in our notes and use other resources and channels to do that. So a couple of things, we're wrapping up here. So I want you to get your questions ready. You can type them in the chat, and we're going to do some Q&A. So we're getting close to the end. But here's some in-visit language for sensitive issues that I have basically worked on over the past year. But if you're covering something sensitive and it's positive, I appreciate what you shared today. Thanks for trusting our team. I want to make sure my note summarizes what we discussed. So if you read it and have feedback, please let me know. Or maybe it's more of a negative sensitive issue and there's a little bit more attention. We covered some difficult topics today. I'm going to summarize it in my note as best as I can. We may have different thoughts on this, and if you see areas we disagree on, please reach out to us. So it is okay to address that there might be conflict or tension, but you're still a partner and wanting to help that patient and showing respect that you care how they might see that. So as we wrap up and you guys are getting your questions, I want to acknowledge a few things. This is a change you may not have wanted. This is a change that may feel very sudden. This is a change which can bring anxiety. And if you think about that, that's a lot about what our patients are feeling too. It's probably a lot of what we're feeling with COVID as well. But you have more information. Now you can make a plan, and now you can work with your team. So we can ride this wave, and we can all improve our quality of life and our patients and caregivers' quality of life too. So you are well suited to do that now. So to end, communication is a prerequisite, and our notes are a tool for communication, and this is going to help us deliver quality care for the seriously ill. Here are some action items. I'm going to leave this up for a little bit. My email is down there. I have talked to other institutions, so I am open to working with your team if you want to do that. I'm also on Twitter. Follow Liz Salmi, follow OpenNotes, follow Dr. DeRoche on Twitter. You'll learn a lot from them. So with that, I'm going to stop presenting, and I'm going to give it over to you, Liz.
Yeah, oh my gosh, that was so good. Applauding on behalf of everybody who's tuned in right now. Let's see here. So we are now moving into the Q&A part of this webinar. We probably have more questions than we can answer, so we're capturing those, and we'll be taking a look at them in the following page. Moderating the Q&A is Deb Wackenheim, the OpenNotes Assistant Director of Research Dissemination. Deb, what are we seeing in the chat box?
All right, there are a lot of questions. So we care for patients and families. There are often many dynamics and important information or perspectives that vary between patients and family members. I'm thinking particularly about differences between patient and family perception on situation and information preferences or different opinions. For example, the patient won't talk about end of life, family is willing. Do we document? What do we document?
Yeah, I think recognizing that we are caring for people with different viewpoints, and does it belong in one note? Does it belong in different notes? If there is a lot of conflict in those notes, that may be a place where it may be marked as unshared or sensitive. But you also want to think, is there a way, instead of saying this is sensitive, to say how I document this in reflecting different people's ideas, I can summarize that without necessarily undermining their approach. And I think that is where each situation is going to present different opportunities and different challenges. And that's where we as teams need to talk about this. So I think we are patient-centered enough, caregiver-centered enough, and we know enough about how we use the words that I have confidence that palliative care people can come up with creative ways that reflect the situation, respect the patient and caregivers, even with different viewpoints, and can still actually use the note as a tool to hopefully advance and reduce the conflict and bring things closer together.
Okay, prognostic information is in our notes, not just for the patient's benefit, it's also something important for colleagues to be aware of as they make treatment plans. If the patient declines to discuss prognosis, how do you also convey prognosis to colleagues who are the original intended recipients of the notes?
I think that's, again, where the inter-team communication may need different areas to do that. So I have started having, like after the visit, to check in with the physician who referred, say, here's what we did, here's what I think the prognosis is. So I'm actually using that a little bit more in my physician-to-physician communication. And also in many EHRs, there's areas where you can write notes to self that are not necessarily released to the patient. Like Epic has a sticky note or specialty comments. The chances for those to be discoverable or found at some point may be there, but in the short term, you may be able to write notes to yourself to be able to keep track of that in a very more explicit and direct way, whereas your note might have more indirect language. So I think this is an area where I think we still should document prognosis, but it should be documented with that permission of the patient, just like we wouldn't barge in and verbally communicate prognosis to them without their permission. We shouldn't communicate through writing without their permission as well.
Is there guidance for discussing concerns about cognition or decision-making capacity? It can take several visits to feel certain that a person's decision-making capacity is impaired, though we might suspect it from the first visit. On the flip side, sometimes we suspect impaired capacity at the first visit, but with time it is more clear it is not an issue.
Yeah, this is a tough one. And I think this is where I think it's important to what your in-visit language is to start to open up these areas. And I think there's ways that we can talk about our concerns about decision-making capacity in the visit that don't seem scary or so off-putting, to say, hey, your thinking sometimes isn't connecting well. That worries me on how we can help you best understand. Over the next few visits, I'm gonna really talk and make sure I understand how your brain is working so that we can make the best decisions together. And then writing something similar in your note can highlight still to other clinicians and to your teammates and to your future self, okay, we're still addressing decision-making capacity issues, but maybe using the language that is not so directly clinical, but reflects what we saw in the visit.
How do you document notes for patients who do not want to know everything about their serious illness? And how do you write notes with cultural humility and competency?
So the first one, if someone is really a strong information rejecter, I've had a couple of patients like this, and first of all, I find that they're actually not on the EHR portal. Like they're not. Or if they are, it's only for technical access for a caregiver or proxy. So if they really refuse it, what I tell them is, I need to document that, and I know you don't want to see that. So what I would recommend is that if you don't want to see any of that information, you don't read the note. Our after visit summary will have instructions. That's going to be the thing that you want to read. But to care for you best and to work with your other physicians and team, I need to write that in there. So I basically kind of help them find out how to wear their limited vision goggles. And the second one, cultural humility. That I think is an ongoing conversation. I think it it probably mirrors a lot of what we try to do when we're in visit or verbally or Zooming, and how we try to do that. We want to reflect respect for individuals, as well as respect for their cultural background. And I think that's where, if you don't feel like you have a good understanding, that avoiding speculation, avoiding too much presumptions is probably important. Liz, do you have any thoughts on that from other specialties and other groups you've talked with?
As far as capturing cultural
differences and humility and.
You know, to be honest, so a lot of the research around OpenNotes, primary care, pediatrics, mental health, and these different specialties, I don't know how much that has come up, and I think it seems like a really uniquely palliative care question to bring up, which is awesome. And I think, like something you said earlier, Dr. Sinclair, was this is an opportunity for more research and better understanding about OpenNotes and palliative care, and that might be a thing that we further explore. I don't know if Dr. DeRoche is still on the line. She might be able to add to that, but I think she actually had to go. We are capturing all the questions, and if we can add more details to that, we'll be putting this out like on a blog post on our website. But I'm glad that question was asked.
Yeah, and for this, and for people who might not want to read all the issues we talked about today, there's an opportunity for anybody to kind of plant their flag and say, I think at least this is the basics of what we should do. And for us, for that to be the starting point. Now, granted, would that have been nice for us to have 10 years to do this? Yes, but OpenNotes has been around for 10 years too. And unfortunately, our field didn't necessarily jump on this. So that's one thing that I followed Liz and OpenNotes for some time. I honestly feel guilty for not banging this drum louder and being like, guys, we need to all do this in our field. But that doesn't mean that we can't do it right now. And there's not an opportunity to do it pretty quick. And still have great conversations and learn from each other in a very collaborative way, which I think we do really well in palliative care.
There are a couple of questions about chaplains and asking what advice you have. And one particular pediatric chaplain said the notes are written often more for the benefit of the staff to understand family dynamics, et cetera. They worry about jeopardizing the ministerial relationship with the patient and family through documentation about conversations, but also worry about staff losing out on some of the valuable insights.
Yeah. And I think especially when you lose the burden of billing being a task of the note, I think that's very important. And I think we may see over the next couple of years a shift in what does the note mean? What does it mean to other clinicians? And what does it mean to patients and families? So I think this is an opportunity to say, let's have focus groups. Let's sit some chaplains and some patients and families down and start having conversations. There's a lot to explore here, and unfortunately I don't have an answer, but excitedly I don't have an answer. And I think there's a lot to explore and understand, and I'm confident that we can do that, and we can do and represent well for our different specialties, our different disciplines, and our field of palliative care.
Do you have specific guidance for inpatient PC consults where referring team members sometimes change daily? Therefore, the note's the primary mode of communicating across time. If we can't put our complex, lasting communication guidance in notes because it may be sensitive, there's no way to keep up with it in person as staff changes shift to shift.
Yeah, and that's where I think the team dynamics and the intra-team communication, we have to figure out, are the notes really the best tool for that? And they may be, and I think we're going to try and figure out what that multi-armed balance is between what the patient may need from the note, what the clinicians may need from the note, and what billing and legal and other people need from the note. I think there will be some shifts in those balance, but I think the other thing for us to do is make sure to ask ourselves, are our notes the best tool for that? Because sometimes they may not be.
I'm going to pause. We are at time, technically. We could probably talk about this all day. I don't want to, there's still 300 of you left, like still watching at this moment. If you need to go back to work and whatever you're doing, please do so. We are capturing all these questions, and we'll be sending out the links to the webinar recorded to our YouTube channel in the coming days, as well as links to all of the slides shared here, including Dr. Sinclair's, here's my note statement all of that for you to repurpose and learn from, as well as the links to all of the resources on the OpenNotes website. As we shut down, Dr. Sinclair, is there anything you want to leave us with? I mean, you're exploring OpenNotes in this whole new space. And I learned so many new things today, and I know we're so surprised and excited about what you've been learning. Any last words you want to share with us?
Yeah, I think it's important for us to recognize this is a tool, and we need to figure out how to use the tool well. It's actually by itself, it's neutral, but it's how we implement it that it can be used and do great things. And I have confidence in our field that we start from a very patient-centered place, that we're going to be able to figure those out. Will it cause some anxiety and stress in the meantime? Yes, but I think together we can really figure this out.
Awesome. And I think what's going to be interesting is we know from helping 250 organizations implement OpenNotes before they had to, before the November 2, that most clinicians, there's a lot of anxiety because this is something new that they're going into. There's anxiety in the lead up. And maybe in that first month, as you're thinking, oh my gosh, we have this new audience who's reading the notes. But 3 months in, that kind of initial anxiety goes away. And we hear from folks, oh, this wasn't as big of a deal as I thought it was going to be. And I will say, from like with my patient hat on, is we have not been reading notes our lives. We didn't know clinician notes exist. So you won't get this big uptick of suddenly all these people are reading notes. It'll be a gradual onset, especially because most patients will read their notes only after their clinicians have encouraged them to do so. So you may say nothing for a few months until you feel comfortable. But once you're ready, start encouraging patients to read their notes, because that's when the benefits come in, where they better understand the care plan, where they trust you even more and are more engaged in your care. So I encourage, as Liz Salmi, the patient who also works on OpenNotes, start telling your patients about this when you're ready. All right. Deb, any final things we need to share? No? Okay. Well, thank you guys so much for joining us today. Thank you for Dr. Sinclair as our special guest. Visit opennotes.org to learn more. Signing off.